All right, so I'm going to basically go into a little bit more detail on some of the procedures of the shoulder and just some little pearls that I've learned, I think, over the years. I won't go over too much of the anatomy. I mean, Dr. Jacobson really, went through that, but I'll just scroll through some of these models quickly. So again, basically on every screen, when you look at your shoulder, you can see the deltoid muscle because it's such a large muscle that overlaps basically the whole shoulder joint. And this is the subdeltoid bursa. Again, Dr. Jacobson mentioned it's a very large bursa. It covers essentially all the tendons of the rotator cuff. This is an older model where I put these like little fat globules in the bursa because there is like fat apparently in the bursal wall, but I think that's more of an academic factor than a real practical factor. And here you can appreciate some of the vasculature that overlies the bursa. You have the anterior humeral circumflex artery, which I guess becomes a factor if you're trying to inject the biceps tendon sheath. But here, essentially, this is a very large bursa that's overlying most of the rotator cuff. And here's a bird's eye view. When people talk about impeachment, I guess if you have a acromion where the supraspinatus tendon can rub under the acromion and get torn or tendinotic, this view kind of helps you kind of appreciate that. And then we're basically rotating posteriorly. And bone landmarks, like Dr. Jacobson mentioned, are probably your best way to kind of figure out where you are. So if you're in the back of the shoulder, a very easy bony landmark is the scapular spine. If you have your probe essentially in a sagittal view, you know everything below that is infraspinatus and everything above that is supraspinatus. Here we're rotating laterally. You can appreciate, again, the tendon supraspinatus, infraspinatus. This is not completely accurate, as we were just talking. There is overlap of the infraspinatus on top of the supraspinatus. I think it's just very hard to tease out exactly the anatomy, how that happens when it inserts. And then we're removing the deltoid muscle, and you can see this very complicated network of the brachial plexus before the arteries and veins. I'm not going to get into detail of that for this course, but that is, it's pretty amazing how we remove all these structures seem to stay in their place and glide with the joint. And then if you remove the rotator cuff, you essentially have this capsule. It's also interesting is you have a rotator cuff cable, which you can see here, which is like a crescent shape, which is essentially thickening of the capsule. And it's kind of like reinforced concrete, where you have different steel like barbs that kind of go through the concrete and reinforce it. And I think this also kind of tethers and attaches the cuff to the capsule, so it kind of becomes almost like a one structure. And then if you look again, bird's eye view of the shoulder, you can appreciate basically like these bony concavities where your supraspinatus tendon lives, your infraspinatus tendon lives as well. You have your transverse scapular ligament, where you have your suprascapular nerve that goes underneath that structure, and the suprascapular artery that goes above it. And it's actually pretty hard to find, I think, but if you can put on your Doppler and find the suprascapular artery, then you know the nerve lives right underneath that. Here's an underappreciated muscle, the serratus anterior. If we have time, I've had a couple of cases recently. It wasn't on the agenda of a scapulothoracic bursitis. It's one of those rare cases. I did a couple of procedures of that. Maybe if we have time, we can go over that. Here, if we're making the actual scapula translucent, you can appreciate the serratus anterior muscle. Basically, it originates from the ribs and then it inserts on the medial anterior border of the scapula. And it's a complex anatomy, especially with serratus, anterior scapulothoracic bursitis. But if you really know your anatomy, then things become clear. So I guess one focus that I have on ultrasound is really to get your anatomy down, because if you don't really know your anatomy before you put the probe on the patient, it's not going to become clear afterwards. So always review and over-review your anatomy. And it's not such a black and white field. Like if you Google different sites, like anatomic structure of so-and-so, you'll find many different opinions, different variations, and there is variability between people. But you'll be surprised how not black and white anatomy really is. All right, so I think that's really kind of the main structures I wanted to go over for anatomy. Okay, so let's just kind of jump into some of the injections. Dr. Jacobson went into all the different anatomy of the structure, so I'll just kind of jump into the actual procedure itself. So here's a case of an isoechoic subdeltoid bursitis. And sometimes, the subdeltoid bursa, which lives between this hyperechoic line on the underbelly of the deltoid fascia, which is I think is, it's part of the subdeltoid bursal wall. And I think that's kind of a confluence maybe of the fascia of the deltoid muscle itself. You can see the superficial layer of fascia above the deltoid muscle here, and then you have this underbelly layer of fascia as well. And obviously this is also integrated again with the subdeltoid bursal wall. But here the actual bursitis is more isoechoic, so it can be tricky because it kind of blends in with the tendon itself. Here it looks like there's an supraspinatus tearing, actually intrasubstance tearing of the tendon itself. So this case can be, I think, kind of tricky because you may say, you have all these different lines. You have 1, you have 2, you have 3, 4, bright, dark, bright, dark. You may want to say, it looks like here's the supraspinatus tendon, maybe this is the subdeltoid bursa, and then maybe this is all just part of this subdeltoid bursitis. But to me, it's pretty clear that this is where the supraspinatus tendon begins and it goes all the way down here. So you have thickening of the supraspinatus tendon with tendinosis, and you have this intrasubstance tearing. And then this is where the actual bursa is. If anyone has any questions while I'm speaking, or if Dr. Jacobson has any opinions to keep me honest, feel free to interject. Again, this is just about a learning experience, just to try to get better at our skills. So here's essentially the technique. So I like to, when I do a subacromial injection, I like to have people lying supine, just anytime you do an injection. So it's better to have them lying flat in case they get vasovagal. Then you don't have to necessarily abort your procedure. So I have them lying flat with their arms straight. And then you don't really need to see the whole supraspinatus tendon. You just need to really see the subdeltoid bursa. And here's my needle going in. So it almost feels like an intramuscular injection for patients because you're really not trying to squeeze the needle underneath the acromion. Here's a little 3D model of kind of doing these procedures. So again, supraspinatus tendon, deltoid muscle, we're making the deltoid muscle translucent. This is an in-plane approach. And we're basically, we're trying to get the needle as parallel to the probe as possible, as Dr. Jacobson mentioned. And we're essentially just trying to get that needle into the bursa itself, above the supraspinatus tendon. One caveat when you do these injections, I like to do it when I have the middle facet of the graded tuberosity in view, because the superior facet, as you saw, is a very rounded facet and it kind of gets in the way when you try to do these injections. Okay, we'll just go through it again. Here's a routine subdeltoid injection. So here's the needle. I have a 25 gauge needle. And just one other thing about this procedure, I'm just going to jump all the way to the procedure. I'm not going to go into the diagnostic part. Whenever you do injections, I think, at least in the beginning, or even as you're doing them when you're more experienced, is you want to have a sterile prep, because look how close the probe is to the needle. It's basically touching the needle. Or sometimes it does touch the needle. So you don't want to not cover your probe. You'll find a lot of people don't cover the probe. They say it's not a big deal. But I have seen, probes like going around with little blood residue on them from, other doctors that cover the probe. And then, if it was me and I knew the patient before, had blood on the probe, and now they're going to do an injection on me with that probe and put that on my skin and then stick me with a needle, I just wouldn't feel comfortable with that. Now, if you clean the probe, what are the chances of actually transmitting, God forbid, any kind of, transmission of disease? I think it's very low, but, I think it's basically almost zero if you cover the probe every time. So whenever you're doing an injection with a needle that's close to the probe, you want a sterile probe cover, sterile gel. It's good to drape the site, so it's almost like a surgical procedure where you don't have to worry about if your probe goes a little bit away or glides over, you're still actually keeping the probe sterile. So that's one just bit of advice. If you're doing knee injections where the needle is fairly far away from the probe, I still would cover it, but I don't think you have to invest in a sterile probe cover. I think you can just buy a non-sterile probe cover. Okay, so here's a 25 gauge needle. You can actually get away with a 25 gauge needle for these procedures just because the needle is so superficial and it's so close to the probe, you can still see it very well. That being said, I still like to use a 22 gauge just because it's a thicker needle, it's still easier to see, and it doesn't bend. here we're injecting the subdeltoid bursa. You can see how much I'm really distending that bursa. I think part of the therapeutic effect is not just from the cortisone, but also to use saline, you kind of mechanically separate these tissue planes if there's inflammation and scarring. I think that provides a therapeutic effect as well. And it's also nice to see at the end of the procedure, you'll see some air within the needle shaft and it kind of contours the tendon itself. I kind of made up some terms. Everyone likes to make up their own things, but I call it a contour sign. So if you see, like after your procedure, you see the injectate and the air within the injectate contouring the tendon, that's a good sign that kind of confirms you're in the right place. So here's another case, this is a more recent case where I used about 2.5 cc's of saline and then I basically did a little bit of cortisone. So here's this patient, supraspinatus tendon. She had a little bit of a rim of, like degenerative kind of linear calcification. And this may be more degenerative, same like Dr. Jacobson mentioned. So I didn't try to barbotage this. She wasn't really complaining of a calcific tendinitis kind of thing. She was more of impingement type symptoms, chronic kind of pain with motion. Here again is her supraspinatus tendon. So again, you have the graded tuberosity, greater superior facet, middle facet, and then we're looking at that tire on a wheel where you can see this little calcific rim. So I didn't actually chase this during the procedure. I just went for this little sliver here, which is the subdeltoid bursa. And before, I know looking at the supraspinatus tendon because you can see basically biceps tendon right here, which we just saw to the right of the screen, right there. And so everything posterior to that is supraspinatus tendon. So here she is, she's lying supine. It looks like I'm using a 22 gauge needle. I don't have a sterile drape, but everything else is sterile. And I'm just trying to get it into this sliver here. So, once you get the needle in, you don't have to try to really panic and try to get it to target or try to get it done quickly. Like, always take your time when you do these procedures. I would inject slowly, see how the patient reacts. If the patient has like a ton of pain, maybe you're actually in the tendon or maybe you're in the muscle, but if they really react, you're probably in the tendon. Then you just slowly inject, and then as you inject more and more, the fluid, which is black, will surround your needle, and it'll be easier to actually see the needle. And I'm just separating those tissue planes. And here again is some injectate contouring that tendon. Okay, so that is that needle, that injection. So let's jump to, this is more kind of early in my career. I used to target the dependent part of the subdeltoid bursa. That's me many years ago, a little more hair back then. So here again is some anatomy. So you can see this rotator cuff cable here, which we just went over before with some of the anatomy, some of that's the underlying capsule. Here are the tendons, here's the bursa. And they're basically going into this dependent part of the bursa. So you may think like, what's the advantage of doing that? And my feelings were, well, I don't have to go near the acromion, I don't have to go really near the tendon, the needle may damage the tendon, I don't want to do that. But then, if you think about it, when we try to heal tendons doing PRP, we actually deliberately fenestrate the tendon with the needle. So I don't think putting a needle in a tendon is damaging. In fact, if they had bursitis symptoms and maybe some tendinosis, it's probably therapeutic in a way. So I don't really do this anymore, but I just want to show you for just for maybe academic sake. But you can still do it, but then again, much of your injectate it may just congregate here in this dependent portion from gravity and whatnot, cortisone or some sort of biologic. And again, you want your injectate to go over the tendon. So, I probably would not recommend this. But this case is interesting because the needle can look like it's in the bursa, but when you inject, you see this bright hyperechoic signal, which is air from the injectate. It's actually going in the muscle. And so this was an intramuscular injection to start. And then I realized that, and then I pushed the needle in until I felt like a pop. And then you can see it spread and burst out. So the lesson from this is, don't go by where you see the tip of the needle, because the tip of the needle looks like it's actually in the bursa. But what it's really doing is it's actually pushing the wall down towards the bone, but it didn't pop through. So you almost want to feel like a little pop, And even more importantly, you want to see your injected go where you want it to go. Don't just say, oh, well, my needle tip is fine, this must be in the bursa, but if you don't see it go in the bursa, it's not in the bursa. Pretty obvious, but you can be fooled sometimes. All right, I'm going to go over a couple more glenohumeral joint injection techniques. So this is an out-of-plane approach. Again, it's best to do everything in plane if you can, but this is an out-of-plane approach, and this is really the way that you do injections widely, essentially. So this is more ultrasound confirmation. It's less ultrasound guidance, if that makes any sense. Because you're not really seeing the needle, but you could confirm after you inject that the injectate is actually in the glenohumeral joint. All right, so let's see, what do we do? So this is the back of the patient. This is a iodine, povidone iodine swab. So here my probe, it's more of an axial plane, it's a little bit oblique. I'm looking at the humeral head, I'm looking at the glenoid. So I really just want to get my needle going all the way down, and I just want to get it underneath that capsule. You don't have to squeeze your needle between the humeral head and the glenoid, as you could potentially damage the articular surface with the needle. Now, whether you can really significantly damage, I think it's unlikely, but I think it's always best to avoid the articular surfaces. So again, this is what I'm doing. You can either go above or below the probe. I like going above the probe, and you can basically do what's called a jiggle technique, because you don't see the needle, but you can see the tissue moving around the needle. So here again, the deltoid is now translucent. Now my needle is going into the infraspinatus muscle and tendon, more tendon than muscle. And now once you're through that, your only layer to go is your capsule. Remember, the glenohumeral ligaments are not posterior. You have your inferior, your middle, and your superior, which kind of line the joint like that. So it's just a thin layer to go, and then you're heading basically right between the humeral head and the labrum. And better not to nick the labrum and glenoid or humeral head if you can. Okay, so that's kind of the technique that I do. And so here's the shoulder, her head's up here, she's looking towards the door. I'm making all my little markies. One thing I would have in mind is try to make one mark on the skin. I think this was a case where I made 3, and then you may, I don't know, you may be a little nervous, you may forget which was the mark that you really like, and then you may not use that mark. So always make, I think, 1 mark if you can, and then know relative to that mark where you want to put your needle. So here I'm pushing on the skin, and it looks like I'm going to head a little bit medial to it. So then I continue pushing. Go a little bit lateral. Here it looks like I'm going pretty straight on. So that's where I'm going to go. That's where I'm going to go. And like any injection, I think your major work is before the injection, is prepping for the injection. You don't want to put the needle in and then try to figure things out. You almost want to visualize the actual procedure before you do it. Okay. And we have, I think, at least one surgeon in our team today. So I'm sure the surgeons, they kind of want to see the procedure before the procedure is done. So here we're going in. This is viscosupplementation for the shoulder. And here it looks like my needle was underneath the probe on this particular procedure. And here you can see, now once the needle is in, you can get a pretty good sense where it is. Here you can see me kind of doing a little jiggle, and now I'm going down here. So this is humeral head, glenoid, infraspinatus muscle, the tendon, and here's the deltoid muscle. Here you're going right through. And then, once you get a sense that you pop through that capsule, then you can start injecting and you're in that posterior recess. I think in this technique, it's probably good to have saline as your first injectate, because you want to confirm where you are with saline. It's probably better not to use the actual material that you're injecting unless you're really comfortable, because you may wind up initially injecting the deltoid muscle, the infraspinatus muscle, and you kind of waste that injectate. So the advantage of this procedure versus doing an in-plane approach is that it's a shorter needle, it's a direct approach to it, and if you get it right, it might be a little bit less painful for the patient, because you don't got to traverse much territory in order to get to the target. All right. Now we're going to jump to calcific tendinitis. We might have some other cases later. So I don't know if I really want to show this. This is just a general picture of basically what Dr. Jacobson did. It's better just to do a one puncture technique and try to get your needle into that calcium glob, because then you essentially have like a closed cavity. So every time you inject saline, it's in a closed cavity, and the back pressure is going to come right back in your syringe. When you do these procedures, you don't have to actually pull back on the syringe. Once you inject, and you usually just come right back. And like Dr. Jacobson said, he had 3 syringes ready to go with saline. If you're not sure, maybe have 4 or 5, depending how big the lesion is. Like I had a case, like not even a week ago, like a huge calcific tendinitis. I think it took up much of the supraspinatus and it took up some of the infraspinatus tendons. I had 5 syringes ready. But that was a case where I noticed that it was kind of leaking through the calcific deposit. So I definitely got a fair amount out, but some of it was actually leaking through, so it wasn't like a perfectly sealed space. All right, here's one early in my career. And just as like a clinical note, like people with calcific tendinitis, they come in and they're like in agony, like they cannot move their arm. And nothing major happened. It wasn't like they fell or they had a cold or anything like that. They may have done something a little bit more than usual, but they come in and they just they can't move their arm. They just move their elbow. And even before you image or scan the patient, that's what I'm thinking, calcific tendinitis. I usually do get x-rays just to make sure nothing crazy going on, but it's also nice to see that calcium on x-ray. So here you can see this kind of globular teardrop calcium sign on x-ray. Here we're just doing like a routine scan, and here is this calcium. So again, going through your layers, deltoid muscle, here is basically the subdeltoid fascia, part of the subdeltoid bursa, kind of intermixed. And here, this little sliver is actually the subdeltoid bursa. Does everyone see that? It's pretty subtle. Here's where the supraspinatus tendon begins, and then you kind of lose it over here. So it looks like this is all supraspinatus tendon above this, and this calcium deposit is almost going to the surface of the supraspinatus tendon. So if you're actually putting your needle in here, you're really not going through much tendon. So let's say at the end of the procedure, you want to fenestrate this kind of calcific rim. I don't think you're really damaging much tendon or really irritating tendon too much because it's right near the surface of the tendon. But one word of caution to patients is, like Dr. Jacobson mentioned, after these procedures, calcium is very irritating and it causes bursitis. So you almost have to use cortisone after the procedure. And you are putting a lot, like an 18 gauge needle into these deposits. If you use anything less than an 18 gauge needle, you may not get anything. So you have to use at least an 18 gauge. You may even want to use a 16.5 gauge needle. So I think, and once you aspirate all this calcium, in my mind, there's like a defect in the rotator cuff now, right? Instead of being filled by tendon, you now almost have like a hole in the tendon. Now, and I tell patients though, I'm not causing that hole. All we're doing is basically trying to evacuate the calcium out of your tendon, but you do have a defect in this tendon even before the procedure. So you don't want patients thinking like you caused that defect. That wouldn't look good for you. But I do think, when you drain these and you cause some bleeding, it may kind of stimulate some sort of healing response. Now, I don't know, are there any good literature on that, that you're aware of? If people have large calcific densities, let's say you drain it, with ultrasound, non-op, because they do bring a lot of these to the OR. How well, or how does that defect, over time? Because you basically over time you see tendon material kind of fill in this gap. It looks like it's, the calcium is resorbing and the tendon is kind of healing. But it would be interesting. I'm not aware of any literature the longevity of what happens with these large defects. But I do tell patients, you have a fragile rotator cuff because you have this defect in the cuff and we're injecting cortisone on top of that. So don't do any heavy lifting for about a good 4 weeks afterwards. I tell them to maintain motion, and I show them some wall slide exercises, some pendulum exercises, but not to do any heavy lifting. All right, anyway, so back to her. So this is this whole globular calcific deposit, and to me it doesn't look, it doesn't look like she has a hard rim or hard shell. This is more kind of in that maybe early mid resorptive phase, so it's easy to actually get out. So jump through. So even like, even the back of her shoulder, this calcium deposit goes. All right, so here we are, we got an 18 gauge needle, and we're basically just getting it right into this, and then we just keep injecting. Here, this is between changing syringes, and you can see how, and I just saw this recently, you see the calcium just dripping out of there. It's like you kind of hit oil. And then you just, keep changing syringes. Once you see it get cloudy, you want to change out. You don't want to re-inject the calcium into the patient. It may get a little bloody because, you're going through tendon and whatnot. And you want to use a sterile gauze pad to change the needle because you can be touching the needle with the gauze pad. And then you just go through a bunch of rounds of these. If you do have an assistant, that's very, very helpful. I don't think I've ever done this by myself. I've always had a medical assistant hand me things because you are going through a lot of syringes. And then we just, it's almost like a fish mouth we create. Just pulls up and closes. And then here it looks like we're injecting our cortisone at the end of the procedure into this subdeltoid bursa. People usually feel better right away. This is one of the few procedures where people are very, very happy. Here I am, very proud of the calcium that I harvested. And here's her aspiration irrigation procedure. Feels a lot better? Okay. How much pain relief did you get? Like 100%, 80%, 10%, 50%?
Oh my gosh. No, the pain is almost gone.
It's almost gone, okay. Okay, so it's almost gone, so it's pretty good. And here we did did a repeat scan. So you see all this like little remnants of calcium. Here's initially. So it's one of those very satisfying procedures with ultrasound. This is where you feel like, yes, you're happy to be a doctor and actually help people. People are very satisfied. Okay. Here's a more recent one. Really kind of similar technique. Just going to show this because maybe just a model may help kind of visualize what's going on. Here's this calcium deposit within the supraspinatus tendon. And then we just basically go in and we just basically flush it out. Even if you don't get it all out, I think, injecting it with saline, you're mechanically breaking it up with the saline, and you can mechanically break it up with the needle itself. So we're just blowing it up, and just eventually, that just becomes smaller and smaller. And not the best animation technique. I probably have to work on this a little bit. But here again, supraspinatus tendon, and then again, just here it is, kind of broken up already, and then you can inject, saline. You're just actually breaking it up even more. This is the saline that we're injecting. So let's see. So this is a more pretty straightforward, simple case. Here's this calcific body. So deltoid muscle, subdeltoid fascia with the subdeltoid bursa mixed in. Here's the actual bursal cavity. Here's this calcific density. So again, 18 gauge needle, sterile probe cover, and you can see how close the needle is to the probe. And this is a really superficial injection. And here we are just getting it basically right in. And then at the end of the procedure, we just inject the subdeltoid bursa. But you got to use a big needle. If you use a small needle, you're not really helping. And we're just doing it again. We're just basically injecting the calcium with saline. Here's the saline needle, supraspinatus tendon. And then at the end of the procedure, again, we just want to inject with cortisone. As you can see here, when the subdeltoid bursa, here's the needle tip. I'll go through some of these techniques later, but if you don't see the whole needle, because the needle goes all the way across, you have to just see the tip. That's where the action is. And there's like what I call swivel. You make like a swivel technique of the probe so you can see the needle in segments. So you want to just make sure you see the tip. I don't want to get too involved with the calcium, but this is a case. This is a huge calcific tendinitis, 60-year-old marathon runner, very active, some very large calcium. This is kind of the way I visualized it, just based on this scan. And then I don't think this really happened, but I did that anyway. But we basically just got our needle into this calcific deposit and flushed it out. We got a lot of calcium out. Again, 18 gauge needle. So, I mean, if you look at it, here's the deltoid muscle, fascia, bursa. Here, this other second, if you see almost like in gout, we'll talk about like a double contour sign. I think in calcific tendinitis, it should be like a double, like hyperechoic line sign or something like that, because you can see here's this bursal wall fascia layer, and then you have this calcium right here. You have all this shadowing underneath the calcium deposit. So it really takes up much of the supraspinatus tendon. So here, just putting our needle in, just flushing it out. And I'm not going to run through the whole procedure, but, and then we're just going to inject our cortisone in the subdeltoid bursa. And what's interesting for him, this is right after the procedure. Okay. Good. So he's got a 90 elbow to the side. That was hard for him. So again, he came in almost with like no motion. Okay. If I recall, this was a while ago. Okay, back down. So even that little motion is very Can you go behind it all? That was the hardest one now.
Yeah.
Go all the way back.
Wow.
All right, good.
Look at that.
And then you see him a couple weeks later.
I don't know if this is my imagination or not. I might even have a little better range of motion. I never had great range of motion.
Okay, so maybe because you had that probably for a while, that calcific maybe just didn't get inflamed for whatever reason.
Yeah, but I see, I have as much just reaching up my back with my hand, my thumb, see how far I can go. I can
That was
go
his
pretty
good
much
arm.
as far. That's my left hand. That's not holding the procedure. I go pretty much as far
Oh,
on my
wow.
right as my left, and I didn't used to be able to do that.
So basically, he had this large calcium deposit in his supraspinatus, and it wasn't painful. I guess it didn't flare up, but it restricted his motion. And now that we got rid of most of that calcium, he actually had better motion before it actually flared up. All right, so
Scott, from a logistics standpoint,
yeah.
are patients coming into you saying, hey, I've got shoulder pain, and you diagnose them with calcific tendinitis, and then you do that procedure at that set time? Or are you bringing them back at a separate date and doing the procedure?
I usually do it that day, just because they're in a lot of pain usually.
Right.
Usually. It's not your typical kind of impingement bursitis patient that comes in, a couple of weeks, couple of months, like, just hurts their up, maybe behind. These are people that are like kind of like shrugging their arm. They're just using their elbow to do things. So they're in so much pain that I say, I think, we should just do the procedure now, because I think that offers, the quickest and best relief.
Sure.
I really don't think they're going to get a whole lot better with therapy very quickly. I think it just may irritate them more in a way. I mean, they could try taking anti-inflammatory medicines, like you may want to put them like on a strong anti-inflammatory, like indomethacin, or even steroids. But I try to avoid steroids. if I
From a
can.
logistics standpoint, you're seeing them in the room, you diagnose them calcific tendinitis, you're saying, hey, look, I'm going to put you in another room where you have like a procedure room where you do the ultrasound and do that sort of stuff, or is it the same room? How does that work, just from a logistics standpoint?
Yeah, I mean, we have, in our office, we have a sonocyte that's portable on a cart, so like, it just kind of goes between whichever doctor needs it. So I don't really have my own procedure room. In the exam room, they're all kind of procedure rooms, so we just wheel the ultrasound machine in and we just do the procedure. It's good to have at least two rooms, because while that's being set up, you can see another patient.
Right.
But yeah, modern day medicine, it's tough. You have patients on the schedule. You don't want to get behind schedule,
Right.
but there are exceptions where people come in with a lot of pain. I just don't feel good just sending them home and saying, you can take some anti-inflammatories or try some therapy.
Right.
I just think, when you're in that much pain, you need to do something. It's interesting though, this last case that I had, she was huge calcium deposit. She had, and I was a little bit like concerned what to do. She had a cortisone injection. This was like a week ago, this procedure. She had a cortisone injection 2 months ago, which I think helped her a little bit. And then her primary care doctor gave her another cortisone injection in the shoulder, which didn't do anything. And then she saw another orthopedist who gave her another cortisone injection, which helped a little bit, but she had like no motion, she was in pain. So she had 3 cortisone injections in 2 months. I usually don't tell people to get cortisone injection more than every 6 months. So the question is, did all that hit the target, first of all? So if it's like an intramuscular cortisone injection, then I'm not as worried. But I'm assuming at least one of them or two of them, got it in, over the cuff. So, and I know if I drain these calcium deposits, I have to inject cortisone. So I'll see. I mean, I drained it, we barbotage it, got a lot of calcium out, and then I just gave her like a real smidgen of cortisone, like 10 milligrams of depot mixed with like 2 or 3 cc's of salines just to bathe that bursa in some cortisone. Because now, I mean, she has a pretty large defect to begin with all this cortisone floating around. So that became a little bit of a logistical challenge. But I thought that was the right choice because she was in such pain, she had no motion. Like, what else are you going to do? And I don't think adding 10 milligrams of depot-medrol is really going to make much of a difference, depending on how much she got already. Yeah.
So how high should it be on your differential, and like what is it insidious onset, like these
Calcific tendinitis is not insidious, it's pretty acute, and I think the diagnosis is pretty clear most of the time. I mean, people come in with really no significant trauma, but with a lot of pain and very limited motion. If you see that, then think calcific tendinitis. And you may not even see it on x-ray. If they have like a more slushy calcium deposit, you may see it on ultrasound, you may not see it on x-ray. So if you get an x-ray and everything looks normal, I would still scan them and look for that calcium deposit. Now, if they're in that much pain and you don't see any calcium on ultrasound and they're still that much pain, I would probably at least do like a subdeltoid cortisone injection. You may want to add some lidocaine for diagnostic purposes. I forgot to mention, for the calcific deposit, I do go in with lidocaine first. So, because I want to numb that whole tendon up, because it is painful to distend the tendon. And that's really the only lidocaine that I usually add. Maybe I'll add a little lidocaine at the end with the subdeltoid bursa injection, but to me, the less lidocaine, the better, but you need to use it at least for that initial stick. And just make sure that you know which syringe is lidocaine and which is saline when you go in initially. I usually put the pink needle, the 18 gauge on the lidocaine, because that's what you're going in with, and then the other syringes, it doesn't matter what needle you have on it because you're not going in with that needle. So you don't have to change out needles on the other syringes because you're not going in with that. All right, AC joint, 47-year-old male with some pain. That's loud. So I really do similar technique to Dr. Jacobson. I think it's easy to go from, let's say, like a lateral to medial approach. So you're going in the joint like that. This is this little cartilaginous disc that, as we mentioned, usually beyond 40, it becomes degenerative and kind of disappears. You don't want to try to squeeze your needle between the two bones because A, that's painful, and it's really not necessary. There is a lot of times when its capsule is a little bit kind of convex and bowed upwards, so you just want to get it underneath the capsule. Here was a case where I went in out of plane and then I thought I was in, but part of it didn't look like it was in, so then I kind of changed in mid-procedure. I just pulled back on my needle and reorientated it, and then I went in plane. So that's not ideal either. I would probably just start from the in plane to begin with. So here's clavicle, here's acromion, here's the capsule. So all you have to do is get your needle in this black space, and then you're in the region. You don't have to, again, go down and try to squeeze your needle between the two. And it's a really shallow injection. It's almost like, think of like a plane landing on the water. Like you're just going in almost like a subcuticular, subcutaneous injection. So here I am, here's my probe, my needle is going at a plane approach, and I see these little bright spots. It looks like I'm in the joint, but then I see some liquid going that looks like maybe superficial. So I don't know if I pulled back or whatnot. I probably could have just pulled back in further, and then I probably would have been fine. But I decided to basically, I wanted to see my tip. So here I can see my tip very clearly. Here's the joint below. So you have clavicle, acromion, and then just in, and then you just inject. A good approach for any joint is just to go to the least painful part of that joint and then inject it. That's one of the advantages of ultrasound. And then I'm just injecting, and you can kind of see that air within the injectate. It's behind schedule. All right. This was not on the schedule, but I think just for some people do like to inject the bicycle sheath. I rarely do this because, as we mentioned, most times this is fluid from the joint, so it really means there's something going on in the joint. But this patient had focal pain right over the biceps tendon. He had some fluid around it. So to me, I thought there was some sort of tenosynovitis within this bicipital sheath. So here's the kind of like an extension of the joint capsule covering the biceps tendon. So this is part of that bicipital sheath. Here's my injected kind of lying over the biceps tendon. So this was an in-plane approach, more of the proximal biceps tendon. One thing you have to keep in mind is that the biceps tendon curves. So your probe is actually not lined up with the humeral shaft. It's actually more like a sagittal oblique direction. Here you can see the needle going into this bicipital tendon sheath, which again is continuous with the capsule. You have your transverse humeral ligament. Here are the glenohumeral ligaments that you can see here. This is coracohumeral humeral ligament, and then underneath that you have your glenohumeral ligaments. So you have your superior, your middle, and you have your, here's the biceps tendon sheath. The inferior glenohumeral ligament is underneath here, kind of in that middle axillary pouch region. Here's this rotator cuff cable. So here's all this kind of large kind of fusion around the biceps tendon. And here it looks like there's some synovitis surrounding it. So I'm just going to jump to the procedure for time's sake. Again, it's fluid, biceps tendon, some synovitis, and he was focally tendon right over the biceps tendon. I think that was really my main reason for doing this procedure. Okay, here we are. This is a long access view of the biceps tendon. We can see the fluid kind of tracking distally. So, one thing just to keep in mind, again, like I mentioned earlier, I'm kind of high up, so the tendon curves around here, and we'll go over that in the small group standing sessions. That if you keep your probe in an axial plane over the biceps tendon, and you just keep going up, eventually you can look at the biceps tendon in long access, because again, the tendon curves around where it attaches over that on the superior aspect of the glenoid at the labrum. So here I am going in. It looks like I have a 20 gauge needle. And this is an in-plane approach, my needle going across. Here's the tendon here, the fluid. I'm just trying to get my needle kind of right above the tendon, through that sheath. So here we are, and then we just inject. Just fast forwarding. You can see the injectate kind of contouring the tendon. Now another approach you can do, you can go out of plane, you can go in plane, but you can go, which I didn't do in this case, but you can go in plane approach, but short access to the tendon. So you can have the tendon in view like this, and then you can go, I would go from a lateral to medial and just try to get your needle above there. I would try to get it above the tendon. I wouldn't try to get it below, because you do that anterior circumflex humeral artery. The only issue with this, which I like doing the other way, is that you have your greater tuberosity kind of in the way. So sometimes you have to just angulate it right to avoid that. Sometimes you have this bony bump in the way. And the same thing with the subacromial or subdeltoid bursa injection. You don't want to see that superior facet of the greater tuberosity. You want to see that middle facet, so this is flat, so your target is easier to access. All right. So this is a more advanced topic. I don't really do many of these, but this was like a no-fault case. She had just a lot of crepitus and she had some crepitus, but just a lot of pain underneath her scapula with a fair amount of crepitus. So this was kind of one of those nerve-wracking procedures, because you don't want to pop a lung. The lung is actually deeper than you think. The scapulothoracic bursa, there's different bursa. There's basically infraserratus, which is basically below the serraceous anterior muscle, and it's between that and the external intercostal muscles and the ribs. And that lies at both the inferior angle and the superior angle of the scapula. And then you have a supraserratus bursa, which is between the serraceous anterior and the subscapularis muscle. So it's a complicated anatomy. This is one of those cases where you may want to go to your room and kind of review your anatomy before you do the procedure. But here's her MRI. She had a little bit of a labral tear. I didn't really see any bursitis under the scapula. I couldn't really. Here's her subscapularis muscle. Here's a model of how I kind of visualized what was going on. So here are external intercostal muscles. Here's your humeral head, subscapularis tendon. This is all trapezius muscle, so we can just kind of get that out of view. When your probe is over here on this medial edge of the scapula, then you have trapezius muscle, you have your rhomboid muscles underneath that, just so you can kind of be aware of what layers you're going through. So now we're making this trapezius muscle translucent, and we're really, what I try to do is, I tried to figure out where she was most tender, and then I did see like a hypoechoic zone where I thought the bursa was, and then I went for that. So let's just kind of fast forward. I don't want to get too involved in anatomy, but here's the serraceous anterior muscle on that anterior surface of the scapula, and it inserts on that medial border. And you have all these muscle slips, which essentially come from all the different ribs that are there. Here's an inside view of the thoracic cavity, where you have your innermost intercostal muscle. And here we are looking at this again. So serraceous anterior subscapularis muscle. So if you have a supraserratus bursa, that would be between the serraceous anterior and the subscapularis muscle. If you have an infraserratus, that's actually that's underneath the serraceous anterior, between that and the intercostal muscles. So just trying to visualize this, I figured just to kind of look at this from different angles. Again, now we're making the scapula translucent. Here's serraceous anterior muscle. And now we're just turning and looking at this from a bird's eye view. So serraceous anterior subscapularis muscle. But our bursa that we went for in this patient was actually, I think it was at the inferior angle. So again, here are some of those structures. Now we're bringing back these muscles, all the different intercostal muscle layers, and here's her bursitis. So this was an extended infraserratus bursa, the inferior angle of the scapula. So when you do it under ultrasound, really I'm just trying to get this medial border of the scapula in view, and I just want to get my needle tip really into this bursa, maybe a little bit underneath that medial border. And I always want to visualize the ribs and basically just the ribs you see. It's really hard to decipher out the external intercostal muscles. And you always want to keep your needle tip in view, because again, you don't want to give the patient pneumothorax. So that's why I think a lot of people shy away from this procedure, including myself. I'm not in a rush to do this at all. And here's the procedure done. Here we're just rotating again, and some of the layers. And this is, again, it's an infraserratus bursa because it's actually underneath the serraceous anterior, and that's really our orientation. The ribs would lie over here. Okay, so actually, this is what I saw. So she was tender here, she had a lot of crepitus. This hypoechoic zone to me was the infraserratus bursa that was kind of sticking out of that medial edge. Here's my needle coming in, going from a medial to lateral. It's somewhat oblique, I think, too. And then I can see my tip, and I can see this medial edge of the scapula. So I'm always trying to keep this tip in view. So here it is, and it's right under that scapula. Here are the ribs. So I don't want my needle going any deeper. Pretty clear of the ribs right now. And then we injected her with this, basically, I did like a couple of cc's of saline with some cortisone. And it actually took away her symptoms, like almost completely. I was pretty impressed, but it only lasted a couple of weeks, and then she came back. So I don't know. Do you have any suggestions for that? I mean, that's not a procedure that I commonly do. Like what you inject, any different approaches. Actually, I remember speaking with you. You actually were the one that mentioned to me that sometimes you see it pop out, underneath that medial border of the scapula. So that was what kind of clued me into that. But it's not a common procedure. But I don't know if you have any pearls of wisdom regarding that.
I do exactly what you do for the approach. My biggest issue is from the diagnostic perspective, because without MR, we don't know exactly what's going on. And I was thinking, do they have a grading scapula? Do they have an osteochondroma? Or what's the cause of this? But I do exactly what you do for the treatment.
Yeah, she actually had, besides an MRI of the shoulder, she had an MRI of the scapula, which is not something, that was maybe the first one I ever ordered, and I didn't really find anything so unusual as far as any major bursitis or nothing obvious, I think, on it. Maybe like a stress reaction to the bone, but she definitely had palpable, audible crepitus, discomfort. She also had a labral tear in the shoulder that eventually got fixed. So, the surgeon thought maybe that's contributing to her pain. But, and there are very few surgeons that actually go in arthroscopically and clean out some of these adhesions and scar tissue. There's very, very few. Even in the New York area, like I tried to find surgeons to do it, and I can't really, it's like one maybe. We're talking, like very top-notch institutions, like very few surgeons go in and venture into this territory. But I don't know, it's an interesting thing. I mean, I had another patient who fell on his shoulders. It's a workers' compensation case. He has like really severe crevitus underneath the scapula. I also injected him, similar approach, and it helped him pretty significantly, not as much as her. And again, it just kind of wore off after a couple of weeks. So, I don't know if a biologic might do better, but I think it's actually like kind of scar tissue that's in there. So there may be, inflammation around bands of tissue, scarring, and then, once, the cortisone wears off, that inflammation sets in again, and then, you have this. So maybe you need to do something surgically. All right, so those are basically some common procedures of the shoulders. Are there any questions?